in a short time.
Okay. Okay. Anyway, I shall I start this presentation, today's presentation, and I will record this the talk, and after that I will upload this video on the YouTube, so you and your colleague can see the later. Okay. Anyway, today my talk is the revision or travel out of the UK. So roughly saying, after the UK, there are 2 times higher revision rate, so-called double trouble after the UK. So many surgeons to hesitate to do the UK because the higher rate of revision and the very difficult procedure. So, can you see this video? There are 2 graphs.
Yes, I can see. Yes.
Okay, chance. Okay, this is Finland registry data. This is the survival rate after. Sorry, this line is TKA. This line is UKA. So roughly saying, the 2 times higher the revision rate after UK than after TKA. And compared to the type of, this graph compares type of UKA. The Oxford UK is the best result. But even the Oxford UKA, it is a little bit higher revision rate. So this is the MG knee, and this is the PCA knee. The countries, the most popular UK component is Oxford UK and Zima UK. This is the following the Miller guarantee UK, the very modern type UK. This is England joint registry data. It is also 2 times higher after the UKA. Even after the adjustment of preoperative condition between TKA and the UK. So there is some reason of so high revision rate after UKA. So should we stop UK? But before stop UKA, we should consider about the UKA. On the contrary, there are so many papers of good 10-year survival rate. There are so many. So roughly saying, the 10-year survival rate should be 98%. It is similar to the TK result. So what is the difference? The registrator is 2 times higher, but in these papers, the revision rate is similar or even better than the TK. What is the difference? And in addition, there are very famous paper. This is a report of 20-year survival rate after the Oxford compartmenting arthroplasty. The 20-year survival rate was reported to be 91%. That will be perfect. This is one hospital data in the Sweden. On the one surgeon in the Dr. Ford, it's very famous. So we can get the good long-term survival rate after the Oxford UK. How to achieve this? So this is a designer's hospital. So it is a non-designer's hospital of 15 years survival rate. So this is the mean follow-up is 11.9 years and up to 50 years. So 20-year survival rate was 90% for any reason, and 90 99.3%, sorry, 96.3% is related to prosthesis, such as loosening, subsidence, so far, so and so on. So, and Oxford knee score is increased from 19 to the 42. Knee society score, the 47 to 81. The result looks perfect. In this hospital, from 2009 to the 2018, more than 1,000 knees are implanted for the patient. So the reoperation or 27. So the percentage is 2.5%, and the revision rate was 1.6%. So in addition, the 7 of 18 revision case is a cementless fracture. So after the introduction of cementless Oxford knee, I experienced so many tibial fractures. So the temporarily I stopped to use cementless, but I analyzed which type of patient is more likely to have the fracture. So I restart to avoiding the high risk patient and only do for the safe patient. So after that, fracture rate is dramatically reduced. So anyway, so to avoid the cementless use, so maybe survival rate can increase, not so bad. So one reason is the surgeon experience. This graph shows the survival rate and the surgeon volume, the annual surgeon volume of the UKA. The red line is less than 10 cases per year, and the blue one is 10 to 20, and the green one is 20 to 40, and the purple one is more than 41. So the patient that do the UK more than 40 per year, the revision rate reduced dramatically. 10-year survival rate should be around 90%. It is similar to the previous report. So go back to the previous. This is the number of cases. This is all of them are high volume operators. So the operator experience is very important. So the operator do the UK more, the less revision case were observed. So this is another report. So this is the case, the number of case per year, and this is the revision rate. So this is the short is around 12 cases per year equal 1 case per month. This is a threshold. If the surgeon do one or more surgery per month, the revision rates reduced within the acceptable level. So, but it is quite difficult to increase the number of surgery itself. But we can increase the percentage of UKA. So, for example, the surgeon do the surgery, arthroplasty surgery, 100 cases. The UKA rate is only the 10%. surgeon experience should be only the 10 case per year. But if the percentage is increased to the 20 or 30%, the surgeon's experience will increase the 20 case and 30 case annually. So this is the one a way to increase the usage of UKA. And the other reports show that the best result will be achieved if the surgeon do the surgery, UK surgery around 40% to 6%. This is the perfect. This graph means if the surgeon do the UK the less than 20 cases, that means the surgeon is in experienced surgery about the UKA. And more than 6%, it means the over indication. The case will include some unsuitable cases, for example, late OA or lateral cartilage damage or ACL insufficiency. So the 40% to 6% will be ideal. So, roughly saying one by one, one to one. The 50% UK and 50% TK will be perfect, I think. So again, 40% to 6% usage of UK will be we can get the best result. Oh, this is that. Okay. Oh, Chanta will coming. Hi, Chanta, welcome. Oh, this report is very interesting. So this is the relationship between two 6-bus OXO G-score category and revision rate. So this graph means if the patient the score, Oxford knee score at the 6 months after the operation. So if the patient has the UKA, the surgeon easy to decide to do the revision surgery. But if the patient has the very low Oxford knee score, but the patient has the TK, the surgeon is difficult to decide to move on to revision. What is so? If the patient has the bad outcome after the Oxford UK, it can be decided to revise easily. Oh, Chandra, please come in. Okay, because if the patient has a very severe pain and but function after the operation, do you want to revise? Or maybe it is very easy to revise because the revision UK surgery is quite easy, but it's similar to the primary TKA. But unlike the UKA, after the TKA, the revision surgery is very difficult to revise. So difficult to open the joint. So sometimes very much bone loss can occur. So many surgeons hesitate to move on to revision surgery after TKA. So this is the one reason of a high percentage of UKA revision due to the very easy procedure to convert to the TKA. So why after the UK revision is so high frequent, very frequent. With one reason is misinterpretation of large lucid line. So we frequently see after the UKA, especially for the cemented UKA, we can see that some larger lucid line like this. So well, sometimes this is misunderstood as the loosening or subsidence. So, but this type of radiolucent is very frequent after the cemented Oxford UKA. Uh, this is this type is we call physiological radiolucent. It's quite normal. So it don't need to be revised. So this is the characteristic is still very thin, less than 1 millimeter, and the clear margin. The other words. So this the H is we can see the osteosclerotic margin and non-progressive. So compare the previous X-ray and 1 month, 2 months, 6 months, and 1 year. No progression, no change. So never to consider this is the loosening or subsidence. So in addition, some patient complains severe pain after UKA. Of course, it is not specialized in the UKA. After the TK, some patients have some unexplained pain. There's quite intact X-ray, no abnormality, but patient explained pain. So sometimes the X-ray shows the larger loosened line and the patient complains pain. So some surgeons decide to revise. So due to by the misunderstanding that is the loosening. So but never revise due to pain or never revise due to the physiological larger lucid line. So after the UK, some patients experienced very severe pain. So as a patient, we need to find some cause of pain. It is sometimes difficult. The one cause is the neural pain. For example, neuroma around the skull, the operation skull, or Hunter canal syndrome. That is the nerve penetrating the fascia or the medial side of femur. So sometimes the patient have the very, very severe tenderness of the medial side of their thigh just above the knee. So in the patient, some block is very effective to the vastus medial muscle. If we inject some local anesthesia into the vastus medial muscle, the anesthesia will extend to around the muscle and reach to the Hunter canal. It is very effective. Or sometimes the patient have some radiating pain, just like the tinel sign, near the operation scar. So this patient inject local anesthesia just near the scar. Then the patient, the pain reduced gradually. After that disappeared around the 6 months or sometimes 1 or 2 years after. But if larger lucid has no abnormality, never revise the UKA due to the pain. So in addition, maybe the one explanation of the unexplained pain is the weight loading stress on the medial side bone here. Because this area of bone is covered by the subchondral bone before the operation. After that, after the implantation of UKA and even TKA, the loading condition is dramatically changed. This tibia tray is directly the contact to the subchondral bone. It is relatively soft, but gradually getting harder and harder to adjust the situation, loading situation, or the mechanical loading situation. After the 6 months and 1 year, some sclerotic bone skeleton can occur. After that, the pain will disappear gradually. So just wait and the so-called bone remodeling. After the bone remodeling, the patient pain will disappear spontaneously. So again, never revise the TKA due to the patient pain. Please just wait. Okay. This is a revision UKA to TKA. There are some paper about the UK revision to the TKA. This is the big number of data of the systemic review. The revision rate, say the UK or TKA, after the UK to the TKA, the revision rate was around 4% after the 6 years. It is similar to the revision rate of primary TKA, not so different. So the revision rate of after the UKA and primary TKA is similar, not so different, and better than the revision TKA. So revision TKA or TK2 after the TK2 TKA revision, the result is worse than the UK2 TKA revision. So it is beneficial for the patient if we think about the revision after the surgery. So increase the primary result survival, increase the primary survival should be very important. If you increase the primary survival rate, even if the patient needs a revision surgery, after revision surgery, the result should be better. Compared to the revision after TK. It is very complex. Okay. So, but revision UK to TK is some technique or some instrument. After the UK, it is characterized by the medial tibial bone loss, such as subsidence of the loosening fracture. So at least one of stem use or augmented use or bone graft is required to fill the gap, the defect of bone on medial side of tibia. So this graph shows that if we use the stem, at least stem or stem with augment, can improve the postoperative results and the survival after the conversion to TKA after UKA. So this is the cause of revision surgery. This is our data The revision rate is a little bit higher after UKA than TK in our hospital. But have a look. Our data is characteristic by the high revision rate due to the fracture. But in the European country, this is small is from Sweden, and the Pandit is the UK, is a designer's hospital. There are no fracture. And of course, after TK, no fracture, but very, very high point. On the contrary, inpatient is very, very rare after the UK. And lateral side OA is the low rate as well compared to the US Western countries. Maybe this is due to the low body weight than the European countries' patients. Those needs are a little bit higher, and unexplained pain is much lower. But this fracture is higher if the, but again, this fracture is mainly after the cementless tibia. If we never use the cementless tibia, the fracture rate should be decreased up to 0.1%. Revision rate is similar to the revision rate of UKA, and it is much lower than the European countries. So the problem is the cementless, but cementless component is beneficial because after cementless, the radiolucent is very, very low than on the cemented UKA. So it is advantage. Advantage is low frequent radiolucency, but disadvantage is high rate revision, especially in the Asian countries. So I focus on to study the cause of the fracture and how to reduce the fracture rate after the UK. And then maybe I will show you the later of the results. So anyways, so fracture is a very, very serious problem after UK. Okay. Okay, this is the end of my talk. In summary, sorry, I have no text. So in the registry data, in the revision rate is 2 times higher compared to TKA. But maybe it is caused by the easy to revise, the misinterpretation of radiolucent line and radiolucent line and the bad clinical results just after the surgery. So improve the result after the UKA. So we need to have the good knowledge and good experience of surgery. So at least to do the UK surgery, at least 1 case per month, 12 cases annually, it is a minimum. After that, so increase the percentage of the UKA. Then the patient can have the good experience of this surgery. After that, the survival rate, the result will be improved dramatically. Okay, thank you for listening for me. Thank you very much. Okay. Tomorrow I will continue this my talk about the UK. I will talk about the complication of this surgery. Okay, thank you joining me, and please see you tomorrow. Have a good night. Bye.